Fantastic. So, Simon, over to you. I'm going to put myself on mute and periodically I will put messages in the chat. If anyone has any questions, then please feel free to add those questions to the chat and we can talk about them. And Simon, I'm sure you like the interaction as we go as well, don't you?
Yes, I love it. Yeah. So that's really, really useful to me as well. So super. Right. Well, thank you very much once again. And with you once again. Can it be that a month has gone by since we were all last together? And what a lot has happened in that month. But the retina remains the retina, the eye remains the eye, whatever else happens. So, first two lectures, we looked at why ultra wide field, and then all about autofluorescent imaging and how that helps us with our diagnosis and everything. I think, as I said to you before, but just to remind, these first few leading up to June are really sort of lecture sessions where I'm trying to introduce you to a lot of the things that we see with ultra wide imaging and what's on the retina. And now we're turning a bit more to some specific bits and pieces, and then what's going to actually happen, how we treat those bits and pieces. And then when we all come together in June for a face-to-face conference, we're going to do a lot more hands-on stuff, and then some really good interactive workshops after that. But the topic for tonight is black blobs and other suspicious lesions. And these sometimes cause so much angst to people. Just what am I looking at, and what do I do with it? And actually, is it relevant at all in a lot of the things that we're doing? So there are many pigmented lesions that can occur on the retina. They can be in the center, they can be peripheral, and as I say, they're not always pigmented. Sometimes they're sort of hypopigmented, but the first thing we need to do is understand what this lesion is telling us. So again, it's this thing of looking at the balance of it. Does what we're looking at, does it look benign? Or does it look a bit nasty? Does it sort of raise our suspicions? Is it congenital? And I think one of the things with ultra wide field imaging I found over the years is just how many times you see people with congenital lesions, and they may be in their 40s or 50s, and they may have actually had this for the whole of their life, and it's never been seen before. So sometimes it's a bit sort of you have to be careful how you talk to the patient about these things, because they may have been missed many times in the past. But also, is it developmental? Where's it come from if it's developmental, and where's it going to? Almost as importantly as well. Is it genetically acquired? And if so, are we looking at the way that this has been acquired in terms of the genetic mapping and routing through the family? And do we need to look at it in terms of future generations in the family, and maybe sort of a genetic counselling almost with the patient? Or has it just appeared? Has it just appeared overnight? And then once we've worked our way around all of that, are we going to monitor this? Are we going to refer it? And if so, how urgently are we going to refer it? And what do we actually want to put in that referral? So often, I think more often than not, actually, patients will show peripheral lesions and they're aware of them. And as I say, ultra wide field imaging often shows these lesions have been present for many years, but have been repeatedly missed. Sometimes, rather beautifully, the patient will report with symptoms, and they will give us clear indicators towards what it is we're looking at. And really careful questioning is always needed as an aid to your diagnosis that you reach in the end. And sometimes you want to revisit that patient and the questions you've asked them and the answers they've given you to those questions, and maybe drill down a bit more into the questioning further. So with vision changes, are they gradual? Are they sudden? With flashes of light, we've touched on this before. Very important to establish what type of flash you've got there. So are they like lightning streaks, or are they sparkles of golden rain? All of these things will give you answers. Are they describing veils or cobwebs or floaters? Where are the floaters? Which eye are the floaters in? What do they look like? All of these things will help you with what you're looking at. Trauma. have they walked into a kitchen cupboard recently? Have they fallen over and hit their head? Or, for some strange reason, have they decided to take up paddle and they've been playing paddle and been hit in the eye with a paddle racket? Interestingly enough, in a recent paper that's just come out from an ophthalmologist, one of the most causes of eye injury nowadays is paddle. So this great new popular sport is actually causing the ophthalmologist quite a bit of problem at the moment. But all of these factors will help you build your diagnosis and your understanding of these. So let's look at some and see what we're looking at and what they actually tell us. So we're going to start with something called peripheral microcystoid degeneration. Now it's very, very common. You will have probably seen maybe not quite known what you're looking at, but it's the most common intraretinal degeneration. And as with a lot of these things, it's commonly age-related. The longer you live, the more it's likely to be there. And it's going to appear like multiple little sort of intraretinal microcystoid cavities, and most frequently seen in the temporal peripheral retina. Now, the word cavity might give you a bit of a clue here. These are small. They're very blurry, indistinct margins, and often with a grey background around them. You have two types, what are called the typical. These are going to occur in all adults, but they may join together. These little microcysts might join together to create larger cystoid cavities. And these are in the outer plexiform layer of the retina. And of course, the split in the retina is the clue. They go on to form flat. So it's sort of joining up of the little cyst to start with. And then you have the reticular type. So reticular, we talk about reticular drusen. Reticular, it means a fine network or mesh-like structural appearance. And again, 18% of adults may be complicated by bullous retinoschisis, where the thing bows forward full of liquid. And OCT findings will help you with these an awful lot. What are we going to do with them? Well, unless there's any symptoms there, really, you just got to monitor them and just note they're there. You don't need to do anything with them. Recognize what they are and then move on from there.
Simon, sorry, can I interrupt just for a second? I
Yeah.
don't know if anyone else is having the same trouble, but every so often I'm missing a word or two that you're saying. So
Oh,
if that is happening, just let me know in the chat and I will raise that with Simon and then perhaps we can just repeat a couple of the words that you go through.
yeah, sure, sure. I don't know what that's. This
No,
can't be my new broadband, please. So thank you for pointing that out. But yes, do let me know.
perfect. Thank you.
So,
Thank you, everyone.
right, so this is the sort of appearance that you'll get with microcystoid degeneration. Again, zoomed in here right into the far periphery, and you can see this sort of very blurred cystoid appearance that you'll see. And this can literally go a long way around the retina in different zones, in different areas. And when we did with the OCT, you see this classic sort of sciatic-like appearance where you've got the splitting of the retina there. So we're looking for these very blurred orangey, sorry, not orangey, yellowy type little cysts in there. Very, very common in the periphery. We're not going to do anything with them. We're going to note they're there. And as if it's in an older patient, then very, very commonly you would expect to see that there. Very common is a pars plana cyst. And this is a fluid-filled sac in the region of the pars plana, so obviously a section of the ciliary body there. The cysts contain clear
Simon,
fluid.
did you say that's not very common or it is common?
It's very, yes, they are common.
Common. Okay,
Yes.
brilliant. Thank you.
Uh, so in the majority of cases, again, they don't cause any harm or symptoms. And often they're literally found by chance during a routine eye examination. And again, because we're using ultra wide field devices, you're going to pick these up far more commonly in an asymptomatic patient. So most will not interfere with the vision or the health of the eye. It's really a variation of the anatomy of the eye itself. Again, age related, and there are specific circumstances where these cysts will form, and one of them is inflammation, and uveitis can often precede the formation of them. So if you've got a patient who has reported uveitis in the past or is prone to uveitic attacks, then obviously this can be a problem. Physical injury or trauma will give rise to them, although that's a much less common cause. Because they're located in the periphery, they don't interfere with the central line of sight. But if the cyst does grow and expand, it can cause new symptoms. So you might have somebody coming in complaining of floaters. So any patient that comes in and says about floaters, we should really be looking at that periphery pars plana there. Significant enlargement of a cyst may well cause blurred vision, but really, again, these pars plana cysts, we want to observe them routinely every 1 or 2 years. If they do become a problem, you've got the opportunity of laser photocoagulation or even a pars plana vitrectomy, where the gel and obviously the cyst then is removed. You look at these things and you think, well, how on earth would anybody miss something like that? But they do get missed, and they are actually quite common. So, as I say, look for the very obvious border effect there. Again, easily muddled up with the retinoschisis, but it's where this appears from is where you need to be looking for. So they're a bullous structure. The bullous effect is like a blister on a figure. That's fluid in there. That's hyaluronic acid in there. And just generally, about 5 to 10% of the global population. So, as I say, when you actually think of that in your normal patient base, there's a lot of your patients out there that have got pars plana cysts. So don't be surprised if you see those. Here's another one that, although quite central, and it could almost be confused with microcysts again. This is a multifocal placoid pigment epitheliopathy. There's a cracking name for you there, AMPPE. Again, it's a disorder affecting young healthy adults. Tends to be more in the Caucasian population, and again, in this particular example, you can see these sort of milky, yellowy, indistinct placoid lesions. In this one, they're located at the posterior pole. It's self-limiting. You would think it would affect the vision because it's so featured on the macula there. And it's thought to be, we don't quite know what's behind it, but it's thought to be an inflammatory response, normally to a generalized viral style illness. So often when you see these sorts of lesions on the retina, it's worth again going back to the patient and saying, when you said your general health was good, do you really mean, are you sure have you had a cold, flu or something like that recently? And again, the patient may change their answer to you and say, well, actually, yeah, I did have a sort of flu-y type thing a few weeks back. And there's your clue as to what you're looking at there. So again, when you see things like this, look at the questioning you're and it's actually more familiar. You'll see as the inflammation stage breaks down and dies down, it's these areas of hyperpigmentation and chorioretinal. This is where you get the pigmentation appearing on the retina. And there is a potential to damage visual function if you've got macular involvement here. And the patient will often complain of bilateral visual loss, photopsia, or even sort of almost blind spots in their vision, which are coincident with these areas of damaged retina. As inflammation dies down, quite often that will improve. Again, when you're seeing lesions like this, if the patient isn't really complaining of blurred vision, it's worth going back and saying to them, well, did you have a flu type instance? And following on from that, did your vision go a little bit blurry? Would you say you noticed anything? It's amazing how recalling things like that will then jog their memory. out here, you can see how with autofluorescence you use the hypofluorescent areas. You can
Sorry,
see,
Simon. We're totally missing these next bits. The, just the last 2 minutes, maybe a minute.
oh dear, I'm not sure. I seem to be,
So when you moved on to the next slide,
yeah.
is it all right for you to just start from this slide?
Yeah. So this is obviously the autofluorescent appearance here then. And you can see here with autofluorescence the hypofluorescent areas consistent with the inflammation that's taken place on the retina. And you can see why patients will complain of loss of sort of seemingly loss of visual field. And you can see the hyperfluorescent area in the centre here where the inflammation has caused interruption to the metabolic activity within the retina. So this is where you may get the patient complaining of blurring. But this is a classic sort of view of this type of lesion, and you can see the effects of the actual effects on the metabolic setup of the retina there. And again, your OCT will show you the disruption of the outer retinal and ellipsoid zones. You get this hyperreflectivity within the retina. So the two images match up very nicely with each other to give you a diagnosis there. Here's a more advanced, more sort of invasive version of it here. And again, this is an image using true color. So you see these very white areas here, but the hyperpigmentation that takes place as the inflammation dies down. And you can see here how the very large areas of hypofluorescence on the retina there. And again, the OCT showing a lot wider area of disruption. So should you know these patients? Well, yes, because if there is a recent viral infection there, you want to understand what's been going on there. And unfortunately, with some of these cases, cerebral vasculitis has been tied to the condition, and you may want to go on, or the may want to go on to actually go as far as a lumbar puncture, looking for increased white cells within the cerebrospinal fluid. So, it's a case of whilst it may have died down, can be some quite serious underlying factors behind it. So what may look like a sort of dormant retinal position here could actually lead to your patient having a lumbar puncture for further analysis. And you can see, because we don't really understand the nature of this condition, because it's characterized as an autoimmune disease, then you've got other systemic conditions that could be associated with it. So sarcoidosis, tuberculosis, mumps is there, but Lyme's disease. And if anybody's ever had Lyme's disease or known somebody who's had it, it really is quite debilitating. So we need to find these things, understand what they are, referral for differential diagnosis. Even though the visual prognosis might be quite good, we need to understand what's behind it. So that brings me on to sort of uveitis as a whole, and a general definition: uveitis, an inflammation of the uveal tract. So you've got various areas of the eye there: the iris, the ciliary body, the choroid, and you will get inflammation of adjacent tissues as well. Uveitis actually is quite a criminal when it comes to legal blindness. As you can see, 25% of cases of legal blindness in the developing world, 5 to 10% of visual impairment worldwide. So these inflammations are really quite important. And in 50% of cases, we probably don't actually know what's causing the thing. And it's probably a systemic autoimmune disorder going on. Just to remind you of some simple rules here: anterior uveitis, the most common form of uveitis, affecting the front of the eye, involving iris and ciliary body. Intermediate uveitis, that bit further back, the middle part of the eye. And posterior uveitis, which we tend to deal with more. The least common type, affecting the back of the eye, primarily involving the choroid, may also involve the retina and the optic nerve. And obviously, you've got panuveitis. Take your pick. It could be any one or all parts of the body. And uveitis is also classified by these other factors. So onset, is it sudden? Is it insidious? The duration, is it limited, so just 3 months and died down and gone, or is it persistent? So if it's over 3 months there, it's persistent. And then the course of the disease, so is it acute, sudden onset, resolved in 3 months? Is it recurrent, where it just keeps coming back and coming back? Or is it chronic, where even with treatment, as soon as you stop the treatment, it comes back again? So general symptoms with uveitis, if it's anterior uveitis, the patient is going to tell you that it's painful. You're going to see the classic redness of the eye, the photophobia, the blurred vision, the watery eyes. Chronic, blurred vision, mild redness, and photophobia again. But with posterior uveitis, pain is absent and redness is not prominent. So this is one of the ways you can differentially diagnose what's going on there. They will have blurred vision. They will have floaters, but it is this absence of pain that's going there. And obviously you get secondary factors there like the damage to the optic nerve, sometimes high pressure cataracts, and it can even cause retinal detachment. Now, this is a retina with uveitis. Now, I remember a few years back, I was at the ARVO conference in Seattle in America, and I attended a meeting with the worldwide uveitis study group who were working with some of the early optomaps. And it was a lovely moment because they used to grade uveitis by how blurred the image was. And they were having great trouble with the optomap system, which is clear. And they actually asked the Optos team there if they could blur the images because they really couldn't understand what was going on because the image of the retina was far too clear, which I've never forgotten that moment because here we are all craving for clear images and they were moaning that the images were too clear. But again, you see these scattered lesions affecting the posterior part of the eye here, and they will be present on all levels when you look at them. And you see the dropping out of the retina and pigmentation as a result of chronic old scars of uveitis here. And the involvement around the optic nerve head here. Autofluorescence gives the real story as to what's going on the retina. So these areas that actually look quite innocuous here, they just sort of look like dropped out areas. You can see they're all dead. They're all atrophied now, and a lot of atrophy around the optic nerve head here as well. So these areas, although they're dead, what this does tell you is that there's no hyperfluorescence in these areas. This is discrete patches of hypofluorescence. So this is actually dormant. So do I need to do anything with this at this point in time? No, you can see the borders are nice and clear, the edges are clear, and the autofluorescence is showing you that there's no ongoing hyperfluorescence, which suggests you've got ongoing inflammation there. So this is probably dormant uveitis. But this one is much more active. You can see a lot more involvement in the center here. You can see some vitreous. There's a Weiss's ring there. And this just all looks a lot more murky. And when we look at it again with the autofluorescent image, now you can see you've got a lot of hyperfluorescence in the area here. And you've got a lot of floating around. So this patient's probably going to be complaining of quite poor vision at this stage anyway. So this is a very active uveitis going on. But again, the difference is quite stark between an active and a dormant, and you don't see these nicely demarcated lesions on the retina. And then we see another active one here, and you can see you've had retinal tears. There's two sets of retinopexy gone on here, and you've got a lot of vitreo vitreoretinal traction going on here. So this is again a very active uveitis. Again, the patient is likely to be symptomatic in this stage. And again, we go back to a very dawn one here, and you see the classic, very neatly demarcated signs of pigmentation, which if we go to the autofluorescent image, on this one, I do apologise. The true colour one will show you the pigmentation that much more clearly there. And this is multifocal choroiditis. So you can see you've got lots of different sites of choroiditis inflammation going on. And all these sites, these different focal points, are known as multifocal choroiditis. And here you can see the effect on the OCT on the retinal pigment epithelium. It's fairly heavily destroyed there. Got a nice little image with the OCT there. So, moving on, we have presumed ocular histoplasmosis syndrome. Now, this might seem a funny one to include here, but actually, it's not that one. And it's connected really to fungal spores of the Histoplasma capsulatum yeast. And you might think, so what? What's that got to do with anything? It's classically associated with cave exploration and then exposure to infected bats, but more commonly nowadays, infected birds as well. And so again, you get an inflammatory response reaction within the choroid, and you get these atrophic scars at the end of the day. The scars have breaks in Bruch's membrane, so you quite often get a neovascular membrane occurring with it. And the patient will be complaining of painless vision loss, distortion in their vision, blurred central vision, and again, blind spots within their vision as well. And this is the sort of classic appearance you get with presumed ocular, and it's called presumed ocular histoplasmosis because there's a little bit of dispute around the yeast spores that are involved and just what's going on. But often these patients will complain of blurred vision, and you see these characteristic signs of change within the retina here. So again, you've got multifocal spot within the retina, and you've got these more classic arcs of lesions here. Again, the pigmentation shows at all levels on the retina. So should you refer these sorts of patients? Yes, because with all these sorts of patients, we want to understand the causative factors behind them. Again, with this sort of thing, if you're seeing these sorts of images on the retina, you need to go back into the patient and just establish a full history of this patient. You know, is there hobby cave exploration? And I think the reason the tie with caves is obviously where the bats live. They live in caves. So, but you can treat these patients. So laser photocoagulation, anti-VEGF treatment is available in the early stages. So again, refer these patients straight away. Another one which again, uncommon, but is actually not that uncommon, Vogt Koyanagi Harada disease. Typically affects persons of colour and ethnic minority groups. Is it more women? Is it more men? Well, depending on which study you want to read, you will get a variation on that, but no specific predilection towards sexual orientation has been discovered. Again, it's an autoimmune reaction. So these lesions you see on the retina are due to inflammation within the retina, and there is an autoimmune reaction to it. So again, we need to understand what's going on. We maybe don't know what the trigger is, but sometimes it can be cutaneous injury. It could be another viral infection, again, just triggering the overreaction of the autoimmune system. So again, we need to, if we're seeing any odd lesions that we think may be associated with this particular group of people, and you've got injury to the skin or a recent viral infection, then we need to suspect these sorts of things and be referring accordingly. Again, it's not that specific when you look at it, but you will see the lesions in the centre and lesions around the edge here. I've thrown that one in because I had one of those in my practicing life and I wasn't sure exactly what I was looking at. The referral brought it in. So again, because it's an inflammation, all suspected uveitis really should be referred promptly to understand the root cause of the problem, and to try and find out what autoimmune route there is there, because each one may require very specific treatments. It may require very specific diagnostic routes as well. So some other ones: toxoplasmosis, the most common cause of infectious retinochoroiditis in humans. You may well, all of you have come across somebody in your career who has had toxoplasmosis. I know the chairman of our low vision group in Bedford was a classic toxoplasmosis victim. Connected very much to cats. Cats are the definitive host for the toxoplasma organism. But this is the tie-up with dogs as well, and the whole thing about picking up dog's muck and things like that. This is the reason why we do these sorts of things. Active disease, floaters and blurred vision, and often a secondary iritis. So they might be complaining of eye pain and redness as well. So again, these patients need to be referred urgently. Here we see a classic toxoplasmosis scar. Now, this patient is going to be probably severely sight impaired. But the reason I've shown you this one is because with a lot of lesions, you can tell so much by what's going on around the margins here. And you can see just how well demarcated this lesion is. If it's a well demarcated lesion, then it's very likely to be dormant. And you can see there's the autofluorescence image, and you can see the whole thing of this being completely dormant. There's a tiny bit of hyperfluorescence around the edge here, but that is dormant. And you might remember from the autofluorescent lecture last month, often you will see what starts off as hypofluorescence, because it's old and it's long-standing, you often see areas of hypofluorescence within the margins as well. So that's a very old, long-standing lesion there. If you don't want to refer a toxoplasmosis like the one I've just seen there, but if you suspect toxoplasmosis in an active phase, you must refer it promptly. It's important to understand the root cause, and prompt treatment can be given to try and limit the vision loss that's going to undoubtedly result there. But again, with an active one, you're not going to see this neat border around it, and you're going to see a lot more scarring in the center there. So uveitis, is it active or is it dormant? Well, autofluorescence is a really essential tool here, because hyperfluorescence suggests you've got ongoing activity. Hypofluorescence suggests dormancy. So if it's dark and well demarcated, it's dormant. But if you've got a lot of hyperfluorescence there and you've got blurred margins, then you need to be referring those, because they are absolutely ongoing. So let's come to some more familiar ones here. So nevus, we've talked about these in the past 2 months. As I said to you in my clinics, as many as 80 to 100 nevi a week in a normal cohort of patients is not unusual. All nevi potentially run the risk of malignancy. So very much like moles on your skin, don't ignore them. Look at them from time to time, check everything's going, because all nevi do run that risk of malignancy. So routine review. And remember, with nevi, they will enlarge normally in younger patients as they grow, because as the eyeball gets bigger, the lesion relatively will get bigger as well. But nevi in an developed eye should be viewed with great suspicion. If they've got overlying drusen, then they're probably long-standing and benign. But if they've got lipofuscin overlying them, the autofluorescence, they are probably a melanoma. I've just reminded you here of uh, the moles there. So you can probably break these down into three different categories. So the classic one, which you say to a patient, well, think of it as a freckle. It's just like a freckle on your skin. It's nothing to worry about. So the freckle, the nevus, most of these are pigmented, but they're flat. They're small in diameter, and they're commonly found in the eye in approximately 5% of the population. You need to monitor them. And then you have the intermediate melanocytic lesions, or IMLs, large nevi. They're larger, they're thicker, and they're in a category which is in the middle. It's not a nevus, it's not a frank melanoma, but there is a risk to these ones more so, and there is a risk of them growing into melanoma. So again, monitoring these is important. And then the melanoma, obviously, pigmented lesions, more than 3 millimeters thick, highly suspicious of melanoma. And sometimes you think you've got a melanoma there, but it may be correct to observe over a period of time to see if they're changing. And I think that's important to bear in mind here, because so many times using ultra wide field imaging and being able to look at the different layers and use of autofluorescence, you will pick up melanomas very, very early. And I think I might have told you of the letter I got from a consultant one time who said, "Would I stop sending in my melanomas so early in their existence?" Because he had to monitor them to be sure they were changing. It was a lovely tongue-in-cheek letter, and but be aware that you will see lesions much, much earlier on using these devices, and therefore there's nothing wrong with these being monitored before we can be sure. So come back to one of my favorite images here. We see a classic. This is probably here, although it's in a very young child. It is a reasonably large lesion there. But characteristically, these lesions, you will see the pigmentation, you will see it at the choroid level, but you will not see it on the retinal level. And again, this is where depth can tell you much in the lesion. So whenever you see a lesion pigment, look at the different layers to see where it's occurring. Here is another IML. This is a large, large nevus, but very thin, flat, and you've got the drusen over the top of it. And when we look at the green channel, you can see the drusen there quite clearly on the surface of the retina. When we go deeper, you see that pigmentation down at the choroidal level very, very clearly, but you just don't see it on the retinal surface. So this is characteristic of this particular pigmented lesion. And interestingly, when we look at the autofluorescence, there is no sign of any activity within the retinal pigment epithelium. There is no sign of any lipofuscin on the surface of the retina. Not sure what's happening over here, and that's a different factor. We can ignore that for the time being. But again, we're not seeing any lipofuscin on the surface of the retina. We're not seeing any metabolic interference. And if you can get an OCT onto it, obviously that is really helpful, because you can see the nevus quite clearly, and you can see the drusen over the top of that clearly as well. So again, a nevus OCT will go a long way to confirming that. This is an ultra wide field scan here. You see the drusen over the top of the lesion, and then on here you can see there's no signs of fluid in here. You've just got the drusen, so a classic nevus. This one here, again, we see it in the true color there, and you can see drusen over top of it, and you can see the lesion quite clearly down there. And another one, a true color image there. Again, you can see quite clearly the lesion there. And again, this is very nicely seen on OCT. And actually, we've got an epiretinal membrane within this one as well. So if I just scroll through, if we look at the raster line coming down here, we see the nevus here, no signs of any retinal disruption, no signs of fluid within the retina at all. And there's the very nice view of the epiretinal membrane there as well. So just to bring up the mole scoring chart again, I know I brought this up to you before, but I really, hopefully now you're all using the moles chart routinely in practice. If you're not, please do start looking to use it because it is a very, very useful thing here. And we can see the management there. So look at this image here. We have there what looks like a nevus, but this could be orange pigment over the top of it. And when we look at the OCT, we can see there is definite fluid there. And you see this hyperfluorescence on the surface. So your mole score would be a 0.211, bringing up a score of 4. Well, that's a probable melanoma. So you're going to refer that rapidly. So again, the pigmented lesions, look to see what's going on, whether you've got any lipofuscin on the surface or not. And that will be a big indicator there. So chirpy, we've discussed this chirpy before. You get different types of chirpy. So this is a solitary or a unifocal chirpy there, and they're congenital. These are the ones you often see in patients, and the patient won't be aware that it's been there at all. And people start getting very much sort of worked up with familial adenomatous polyposis here, and bear tracking. Is it to do with FAP? Is it not to do with FAP? I just want to look at this in a little bit of detail here because although a chirpy is asymptomatic, you will see quite a few of these, and you'll have the solitary, the unifocals, and you will have the multiple lesions as well. And they can vary in size. They can be very small, up to several disc diameters. They may have a marginal white halo around them, and they may have these lacunae. And if you remember, I said in an earlier talk that these lacunae can actually join up as happening here, and eventually you will have no pigment in there at all, and you will just have that thin margin around the edge. So this is where the autofluorescent comes in because it will give you a dark area there. So again, look for those. This is a classic where we've got a solitary unifocal lesion here, but we've also got multiple or bear tracks here. And you can see very, very clearly on here how with the autofluorescence, this shows up very, very clearly indeed. So when should we get worried about bear tracks? Well, this little table, I hope, will help you. The unifocal chirpy, it's not usually associated with any conditions at all. It's benign, no referral. And typically, it's unilateral. When you come to bear tracks, you get multifocal ones. They're usually confined to a single quadrant of the retina. So that's one of the sort of specifics there. They're unilateral. You're not going to see them in both eyes, and they're usually confined to a single quadrant. But chirpy associated with polyposis, they're bilateral, and they extend into different quadrants, and they often have this sort of pisciform appearance. So if you're seeing this in both eyes, and it's extending across the retina across more than one quadrant, these are the ones that we need to be referring because there we need to be looking towards the link to colonic changes in colonic cancer. Where do you refer them to? You could refer them to a colorectal surgeon in the first instance, but I've found over the years it's better to refer them to an ophthalmologist and let the ophthalmologist make the decision from there. What I have found is if you tell your patient in the middle of an eye test that you're referring them to a colorectal surgeon, it tends to panic them far, far more because they weren't expecting that one. So I think if you're going to refer to an ophthalmology reasoning. Choroidal melanoma, well, it's the second most common intraocular tumor. And as I say, I think these figures are quite low. I think we will see more and more melanomas over the years just because we have the technology to see them that much earlier. And I know I've lost count in my career of how many choroidal melanomas I have referred. And at university, I was told you may see one in your career, you'll be unlucky if you see more than three. Well, I've lost count. And I know I was at university quite some time ago, but I've lost count of how many I saw in my career. So it is the diagnostic ability, I think, that helps more. So they're greyish to brownish. They're located in the choroid with overlying retinal vessels. Some are amelanotic, and I've always been surprised just how many melanomas do not have pigment. They tend to be more than 2 millimeters thick. They have subretinal fluid as they progress. And this thing of orange pigment, the lipofuscin accumulation over choroidal melanomas is a common finding. I always say think of it as somebody sneezed on that retinal image. Don't forget, you will see other things on the surface of the retina, drusen, which are much more commonly associated with nevi. And here's what I've shown you before, I think. This lesion, classic non-pigmented lesion, difficult to tell against the whole of the retina because it's a very pale retina. But when we look at the autofluorescent image, we get this classic appearance of this. It looks as if someone sneezed all over that. This is the hyperfluorescence of lipofuscin on the surface of the retina. This dark thing here is an artifact. So if you're seeing something like this on the surface of the retina associated with a pigmented or even a depigmented lesion, you must consider the chance of melanoma. And again, this was a melanoma that we referred very, very early on in its day, and they had to monitor it over a period of time, and you saw these other changes occurring. But again, it's sneeze-like, glomerular-like appearance of the lipofuscin on the surface of the retina. The earlier you can find these lesions, the easier they are to treat and the better the outcome from there. And so this is really, really important for you to find these early. Here's another one here, very much like the pigment you're beginning to see down the side here. We've got pigment here, but the thing I want to bring home to you here is when you look at the autofluorescent image, here you've got this sneeze-like hyperfluorescence on the surface of the retina again. And you've actually got penumbra of hyperfluorescence here. And that's because the head of the lesion is pushing up, stretching the retinal pigment epithelium, which interrupts its normal metabolic performance. So again, this is a classic view of a melanoma here. And this is the one I used on my front slide here. And you're beginning to see hemorrhaging here as well. This is just another large window defect here. But I think, again, the thing to look for with melanomas, remember I said about those lovely distinct margins you see on dormant lesions? This just looks odd. It's the wrong shape. It's ill-defined. There is your clue there. You can see it on all levels of the retina. But then you go to the autofluorescence and you see again this sneezed out glomerular hyperfluorescence on the surface of the retina, lipofuscin on the surface. And you can see the whole sort of head of the tumor pushing up and that penumbra of hyperfluorescence there, again, where the retinal pigment is being stretched and the metabolic function is interrupted. Now, I thought I'd just show you this because I was just thumbing through the other day the newspaper. There's in a copy, an edition of The Independent in February, and it was the classic "The Optometrist Saved My Life" type headline. And what I loved about this, I was just looking at this, and this was actually in the background of the newspaper, the photograph taken in the newspaper article. I think we had the optometrist and the patient, and this was the screenshot on the background of the photograph. And it was just rather lovely because there's the fluid in the OCT, but look, there is that classic glomerular sneezed lipofuscin on the surface of the retina. And that was actually just in a newspaper article. It just brought home to me how we need to be looking for that sort of thing. Okay, retinitis pigmentosa. This is actually one of the most complicated genetic conditions. There's over 80 causative genes that have been identified, and faults in any one of these genes can cause the disease. So this is where we need to look for genetics within a patient, and we need to be asking the patient very much about their family history, not just mum and dad, but uncles, aunts, and then we need to be looking at possible genetic counselling as we go forward into the next generation. The classic mottled appearance of the retina, the pigmented lesions, you get the bone spicule type patterns there, the appearance of the optic disc looking waxy and yellow, and the attenuation of the blood vessels. So it's a classic sort of ret pig there. And you've got the very classical appearance of these pigmented lesions here. And again, you can see it on both levels of retina, and the autofluorescent brings you that really true reasoning. The pigment obviously will look dark, but you can see the effect of the atrophic hyperfluorescent areas where the visual field defect is going to be the problem. But one that you can confuse this with is this pigmented paravenous retinochoroidal atrophy. Now, again, I hadn't seen many of these, and then I saw one day, and I wasn't quite sure what I was looking at. But having seen one, I've seen so many of them since then. And again, these aren't uncommon at all. But the thing here is it is often completely asymptomatic, and you discover it incidentally. Middle-aged adults tend to show this. It's benign, it's very slowly progressive. It's generally non-inflammatory and non-hereditary. And as I say, it's slowly progressive. And visual prognosis is actually good with it. So although image-wise it can look quite horrendous, actually you could refer these purely and simply for a confirmation of diagnosis. But although it looks horrific, you don't need to do a rapid referral on these. But interesting is the pigmentation doesn't look or similar to retinitis pigmentosa. You've got the sort of bone spicular appearance, but characteristically here, only along the veins. The arteries and arterioles are not involved at all. If we go back to the ret pig, you can see it's no respecter of any blood vessels at all. It's going to appear on and around any of the blood vessels. Well, this next condition is only associated with the veins. So again, when you see a pigmented lesion like this, easy to jump to the conclusion it might be ret pig, but look at the image carefully. What is the image telling you? And when you look, you can see it's telling you that it's only the veins that are involved. So we can rule out genetic conditions like retinitis pigmentosa just from the evidence on the image. Again, it's available at this level, but this is the most stark one. The autofluorescence shows these very large areas of atrophic retina, a lot of sort of dead retina with a lot of what looks like ongoing hyperfluorescence along the veins. To all intents and purposes, this looks like a very active condition, and it could sort of almost worry you that it looks that bad. But once you've made the diagnosis, you realize it is a slowly progressive and it's not really going to impact on the vision that much. So, as I say, refer this one if you want to, but do not refer it urgently. Refer it routinely for confirmation of diagnosis. But again, before you do, look at what the image is showing you in terms of evidence that's there. So, in summary, Black blobs and lesions are seen in numerous forms on retinal images. Most of them will be innocuous. Most of them are not a problem. So when you see a lesion, do not assume the worst. Start from a sensible level of this is probably innocuous. Work out whether it's new or old, active, dormant, benign, or malignant. So look for the clues. Is the patient helping you with anything? What's the vision like? What's their general health like? And then look at what the image is showing you. Look at the lesion borders very carefully. Distinct versus indistinct. If it's indistinct, there could well be activity going on there. Look at the autofluorescence, look for live metabolic clues going on there. So remember, brightness suggests recent onset or ongoing activity. Darkness suggests atrophy and dormancy. So answer all these questions, build up a picture of what the image is telling you. If at the end of all of that, you're still not sure what's going on, then obviously you need to refer that patient, but include all the data. Please do include the images and include the data and your thinking within that referral. We're there. And I'm sorry about what's been going on connection wise.
Oh no, that's brilliant. Thank you so much. It was really, 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 really informative. I learnt loads. Thank you.
That's how I'm glad that's what's going on. So,
Um, just want to double check. Yes, there was a few little bits that we just kept missing, or at least I certainly kept missing.
yeah.
Did any of our audience have any specific questions or just wanted to just refresh on things that they perhaps didn't quite catch fully? Mm. Not getting anything on the chat other than thank
Well,
yous.
well, that's good. I'll feed the hamster next time, just in case he wasn't running around in the wheel fast enough. But
Brilliant. That's brilliant. I just
I don't know what's happening. But my end it seems okay, but I'm not sure. So,
it,
but
it the way of the world. Give me one moment. I'm just going to stop recording.